Hello, hello, hello. Thank you for making the effort to come back and for taking time to get this menopause education. I think it's the education that all women deserve. This is our thorough unit on breast cancer. And my goal is to teach you everything I possibly can teach you, short of tailoring everything specifically to you personally, because that is only possible in a consultation. But I have systematically taught you all about the many risk factors for breast cancer. The very first video on risk factors was video number 366. And here we are at video number 378. So that's a lot on risk factors. We've created a big chart of all the risk factors that I shared with you many times. It consists of 17 different things that increase your risk for breast cancer. Here it is yet again. But despite the long list of risk factors, there are always attempts to create gadgets and equations to assess risks for various diseases. And these are always called risk assessment tools. You saw that risk assessment tools exist for heart attack and osteoporosis. And they exist for breast cancer too. So that's what we will discuss today. All of chapter 30 in both my first and second editions of my book is on breast cancer. However, I do not address risk assessment tools specifically in the book. If you watch this video, you'll understand why. Generally speaking, a risk assessment tool is a means of assessing the risk of a disease using a formula or equation to provide the probability of getting a particular disease within a specified period of time. Some risk assessment tools are designed for use on a population-wide level. This means that they determine the theoretical risk of getting a disease for a particular population of patients with certain risk factors for that disease. Other risk assessment tools are designed for use on an individual level. This means that they determine the probability of a particular patient getting the disease based on her personal risk factors for that disease. So I'll present the risk assessment tools that exist for breast cancer and explain their differences. And you can decide if you think using a risk assessment tool is worthwhile or not for you. There are 5 risk assessment tools for breast cancer. That's right, 5. Most are used only for women with a high risk of breast cancer based on the list of risk factors I've presented in previous videos. So, if having a lot of the risk factors on the list isn't enough to convince you that you are at high risk of breast cancer and you need an actual calculated probability of your risk of breast cancer, you might want to consider using a risk assessment tool. These tools are also commonly used by insurance companies to determine which patients are eligible for various tests or preventive measures. Sometimes they are included in guidelines and sometimes they aren't. For instance, sometimes these risk assessment tools dictate who should consider having genetic testing. Sometimes they dictate who should consider medical or surgical preventive measures. Sometimes they determine what insurance will cover. The question is, do they tell you anything that induces you to manage your breast cancer risk differently than you would have without the risk assessment tool? So to begin, I'll give you a list of the various risk assessment tools and then we'll address them each just very briefly. The currently available risk assessment tools for breast cancer include the Gale Model, the Klaus Model, the Tyra Cusick Model, the BRCA Pro Model, and the International Breast Cancer Intervention Model, also called the Ibis, I-B-I-S tool. I find it interesting that collectively these are all called risk assessment tools, but that they all have the word model in their names rather than the word tool. Maybe that's because the word model is a more feminine word than the word tool. Maybe they should be called breast cancer risk assessment models. But maybe people would mistake them as models for clothing instead of models for breast cancer. But like models for clothing, the goal with breast cancer risk assessment models is to choose the one that's right for you. I mean, which model wins? If we had to assess the models in this top model sticker book, which would win? This one, or this one, or this one? Every risk assessment tool assesses only certain risk factors. That's what I find disadvantageous about them. I mean, there's a big, long list of risk factors, but each risk assessment tool picks and chooses which ones it uses to designate the probability of breast cancer. So let's see which ones use which risk factors. First, we have the Gale Model breast cancer risk assessment tool. The Gale Model is the oldest and most widely used tool for breast cancer assessment. It takes into account 6 historical components of your breast cancer risk factors. Breast cancer history in your first-degree female relatives, your current age, your age at the time of your first period, your age at the time of your first live birth, the number of breast biopsies you've had, and the presence or absence of atypical hyperplasia. And the resulting score gives you a 5-year and a lifetime risk of breast cancer. A 5-year risk of greater than 1.66% is considered high risk. But interestingly, the average 59-year-old woman has a 5-year score of greater than 1.66%. The shortcomings of the Gale model are many. Obviously, the first shortcoming is that of the 17 risk factors for breast cancer, it incorporates only 4 of them and adds 2 pertaining to biopsy results if you've ever had any biopsy results. And of the 4 risk factors it includes, none of them falls into the categories of risk factors that have the greatest impact on your risk for breast cancer. Of all the risk factors, it only includes some of those in the categories of family history, which is 5th in degree of importance and only encompasses 15 to 20% of breast cancers. Age, which is 7th in degree of importance and only encompasses 20 to 25% of breast cancers. And 2 reproductive factors, which are 6th in degree of importance and encompass only 15 to 20% of breast cancers. A second shortcoming is that the Gale model is not useful for non-white women. I mean, can you believe that? I mean, why not? And why not adjust it so that it is? I find this odd because when I look at the risk factors it utilizes to assess your risk, not a single one of them has anything obviously dependent upon race. And let's not forget that you learned in video 368 that black women have an increased risk of breast cancer of 28%. So why in the world would the Gale model fail to acknowledge that and fail to benefit those women? Third, the third shortcoming of the Gale model is that it's pretty inaccurate. For instance, even though a 5-year risk of greater than 1.66 is considered high risk, there's a 98% chance that you won't get breast cancer even with a Gale score of 1.7. So the score and the actual statistics are contradictory. And while all of these statistics seem to apply to the individual woman rather than to the population of women at large, that is not the focus of the Gale model. The Gale model is much more useful on a population-wide level than it is on an individual level. It accurately determines the number of women who will develop breast cancer in the next 5 years on a global scale, but it does not accurately determine if you will develop breast cancer in the next 5 years. So what do you care about the most? Yourself or the whole population? The second risk assessment tool is the Klaus Model. The Klaus Model is used to assess the risk of breast cancer in family members when there is no known hereditary cause. So this is for the category of familial breast cancers, and you've learned that breast cancers based on family history alone account for only 15 to 20% of breast cancers. The Klaus model takes into account an entirely different set of risk factors than you saw with the Gale model. And instead of assessing your personal risk factors, it assesses the history of breast cancers in your family members on both the maternal and paternal sides of your family. Now, because you're such a good student here at Menopause University, I know you're probably thinking or saying, hey, you taught us that it's only your maternal relatives that matter. And if that's what you're thinking or saying, I am very proud of you. The reason this model takes both maternal and paternal relatives into account is because instead of assessing your risk for just breast cancer, it also assesses your risk for ovarian cancer. And as you'll learn in the next unit, your risk for ovarian cancer is affected by both your maternal and your paternal relatives. The Klaus model takes into account the age of breast cancer diagnosis in any first or second degree relatives, any breast cancer before the age of 50 in family members, family history of bilateral breast cancer, family history of ovarian cancer, and family history of invasive lobular carcinoma. So the Klaus model focuses entirely on one risk factor for breast cancer, family history. It makes no attempt to provide a risk assessment score for the 80 to 85% of breast cancers that are not due to family history. So the Klaus model is very limited in its use. It ignores you, your age, your reproductive history, your breast density, and your lifestyle, and focuses solely on other people. The third risk assessment tool is the Tyra Cusick model. The Tyra Cusick model tries to address the limitations and shortcomings of the previous two models by including a variety of risk factors. It takes into account your age, your body mass index, or BMI, your reproductive history, your history of both benign and malignant breast diseases, and your family history. So it includes one of the 5 lifestyle factors, but not the most significant ones, which are smoking and alcohol intake. And it includes reproductive history, which is 6th in degree of importance. And it accounts for only 15 to 20% of breast cancers. It also includes age, which is 7th in degree of importance and accounts for only 20 to 25% of breast cancers. The good thing is that it takes your personal cancer history into account, but that only matters if you've had breast cancer or breast disease. I mean, it seems to me that you already know you're at high risk of breast cancer if you've already had breast cancer. However, it may be useful to assess your breast cancer risk if you've had one of the benign breast diseases that I presented in video 360. This one calculates only your personal risk of breast cancer rather than a population risk. It tends to be more accurate, though, than either the Gale model or the Klaus model. The problem is that it's still considered only a research tool. Now, this is a shame because of all the models, it's probably the most accurate. But because it's only a research tool, your doctor has no access to it. And you're stuck with the less accurate risk assessment models. The fourth risk assessment tool is the BRCA Pro model. The BRCA Pro model is all about the probability of having a genetic mutation of the BRCA type. It assesses your probability of carrying either BRCA1 or BRCA2 or both on the basis of your own cancer history and that of your first and second degree relatives. And again, you may be protesting, hey, you said it was only first degree relatives. And once again, the reason it considers both first and second degree relatives is that it assesses risk for both breast and ovarian cancers. There's a lot of overlap between breast cancer and ovarian cancer. And that's why some of these risk assessment tools seem to be overstepping the bounds of what's important for just breast cancer. The primary use of the BRCA Pro model is in determining whether or not it would be wise for you to have genetic testing. Of course, you can have genetic testing anyway. You do not need this or any other model to give you permission, unless your insurance requires it maybe. If your BRCA Pro results indicate a low probability of carrying BRCA1 or BRCA2, then genetic testing is very likely to be negative. If your BRCA Pro results indicate a high probability of carrying BRCA1 or BRCA2, it might induce you and your family members to have genetic testing. This risk assessment model is only useful if you would use the results to employ breast cancer prevention measures that are more invasive than the norm. And I'll be presenting those to you in a much later video in this unit when we address options for preventing breast cancer. The fifth breast cancer risk assessment tool is the International Breast Cancer Intervention Model, or the IBIS tool. It is like the Klaus model in that it is mostly useful for assessing your risk of breast cancer based on your family history of breast cancer. Essentially, it's midway between the Klaus and the BRCA Pro models. It is more accurate than either one of those, though, because it includes some clinical factors other than just family history. However, it tends to overestimate risk compared to the other models. Now, one of the interesting things about all of these models is that they all exclude your breast density as a risk factor. And this is interesting because, as you've learned in these videos, breast density is a reflection of a lot of the other risk factors for breast cancer. Plus, dense breasts account for a whopping 50% of breast cancer simply because dense breasts are a result of so many other factors and because 50% of women have dense breasts. I also think it's odd that these risk assessment models focus more on the categories of breast cancer that warrant confirmation of risk the least. Think about it. Hereditary breast cancers due to a genetic mutation account for only 5 to 10% of breast cancers. But these are the easiest to detect by simple genetic testing. So why do we need a risk assessment tool for them? Familial breast cancers constitute only 15 to 20% of breast cancers. These are not due to a genetic mutation, but they're also easy to detect by simply looking at which relatives and how many relatives have had breast cancer. Sporadic breast cancers constitute all the rest, 70 to 80%. These are the ones that warrant extra tools for assessment of risk, but this is the category of breast cancers that is least served by these tools. This 70 to 80% of women are the ones that have nothing to make them suspect that they are at high risk for breast cancer. And to me, that's the group that benefits most from risk assessment. Another very interesting thing about these risk assessment tools is that these models are strikingly inconsistent with one another. All you care about is knowing your risk for breast cancer, but by choosing one model versus another, you could get very different results. I'll give you a couple of examples using just the three most common risk assessment tools. the Gale Model, the Klaus Model, and the Tyra Cusick Model. And I'll use younger women simply because that will enable us to get more of a lifetime risk assessment. Okay, for case one, let's say you're a 39-year-old premenopausal woman. You had your first period at age 11, and you had your first of 2 children at age 19. Your body mass index is 22 kilograms per meter squared. You recently found a suspicious mass in your breast. So you had a mammogram and a breast ultrasound followed by a breast biopsy. And the biopsy revealed atypical hyperplasia. You have no family history of breast cancer. Okay, so if we calculate your lifetime risk of breast cancer using this information for these 3 risk assessment tools, you get an 18.3% lifetime risk using the Gale model, a 27.6% lifetime risk using the Tyra Cusick model, and you cannot use the Klaus model at all because it only assesses family history. The 18.3% of the Gale model is considered a moderate lifetime risk. The 27.6% of the Tyra Cusick model is considered a high lifetime risk. As you can see, depending on which model you use, the results can differ greatly. So, for this case, this model wins. For the second case, let's say you are a 35-year-old woman and you had your first period at age 11. You have never been pregnant and you are currently on birth control pills. 2 of your aunts have had cancer. 1 maternal aunt had breast cancer diagnosed at age 40. 1 paternal aunt had ovarian cancer diagnosed at age 55. If we calculate your lifetime risk of breast cancer using this information for the 3 risk assessment tools, you get a 12.4% lifetime risk using the Gale model, a 23.2% lifetime risk using the Klaus model, and a 31.7% lifetime risk using the Tyra Cusick model. Here, the Gale model seriously underestimates your risk because it does not take your paternal relatives into account. Likewise, the Klaus model underestimates your risk because it does not consider ovarian cancer in the calculation. The Tyra Cusick model is the most accurate this time. And if you were to employ the BRCA Pro model, you might discover that you have a high probability of carrying the BRCA1 or the BRCA2 gene mutations. If it turned out that one of your aunts carried a mutation, you would have a 65% lifetime risk for breast cancer and a 45% lifetime risk for ovarian cancer. If both of your aunt's genetic testing was negative, you would have an average risk for both breast and ovarian cancer. So in this case, this model wins. The message here is that these risk assessment tools are useful for different women in different circumstances. No single tool is proper for all women, and which one is best for you depends on your situation. It seems to me that if there are different risk models for the same disease, they should at least agree on your degree of risk. But such is not the case here. If we make a chart to show which of these tools considers which risk factors, it looks like this. All I've done here is use the skeleton of our risk factor chart to incorporate these 5 risk assessment tools. Across the top row, you see the category of risk factors in the first column, the percentage of cancers in each category in the second column, the degree of contribution of each risk category in the third column, the actual risk factor in the fourth column, and the 5 risk assessment models in all the other columns. And I've put stars in the cells to designate which risk factors each tool takes into account. And by comparing them, you can see that they definitely do not focus on the same risk factors. You can find this chart in the usual spots at menopausetailor.me or in the description box below this screen. The bottom line is the same as what you've seen for all other risk assessment tools for all the other diseases. If you know the list of risk factors, you really don't need a risk assessment tool. And if you use one, be sure you use the one that is most appropriate for your situation. They are not all created for the same purpose. Okay, my dears, that's it for today. Next week, we will launch into a series of videos on the effect of various hormones as they pertain to breast cancer. Between now and then, you can find me on Facebook, Instagram, Pinterest, and Stories. And right now, you can subscribe to my channel and my newsletter. And at any time, you can go schedule a consultation by going to menopausetailor.me. I do them all via video conferencing, so it doesn't matter where in the world you live. Bye.